Hi there, my name is Mike Pishfine. I'm an associate professor of GI medical oncology at Johns Hopkins University. Welcome to our case presentations. We have a wonderful panel here with us today, and we're going to go around and meet an individual member first and then discuss some cases. I'll go next to Dr. Fromm.
Yeah, hi, I'm Tyler Fromm. I'm an assistant professor of radiology at the Washington University School of Medicine in St. Louis. I have appointments in abdominal imaging and nuclear medicine, and I'm happy to be here today to go through these cases.
Hello, I'm Pritesh Patel, Associate Professor of Radiation Oncology at Emory University, focusing on GI malignancies.
Hi, I'm Dan Catenacci. I'm a GI medical oncologist at the University of Chicago and an associate professor there.
Hi, I'm Marty Weiser. I'm a surgical oncologist and colorectal surgeon at Memorial Sloan Kettering Cancer Center.
So this is a 52-year-old female with a history of a T3N0 distal rectal cancer, had chemoradiation, surgery, and then adjuvant capecitabine, and now has a recurrence 14 months after completion of treatment. So what are the next treatment options? So the patient initially presented with abdominal discomfort and an ECOG performance status of 1. They have a medical history of hypertension, diabetes, gastroesophageal reflux, kidney stones, and FAP, which we'll talk about. Social history of no tobacco, alcohol, drug use, and she's is a patient, a school bus driver, and again, it has the family history of FAP. So in 1990, the patient underwent a subtotal colectomy after diagnosis with FAP, and then was lost to follow-up, as unfortunately often happens. And then in 2019, the patient had a colonoscopy that revealed multiple sessile polyps in the rectum and sigmoid colon, with one rectal lesion measuring 35 millimeters, the biopsy of which revealed an adenocarcinoma. The CT scan did not show any evidence of disease in the chest. And then in the abdomen and pelvis, I believe we do have that CT scan, Dr. Fromm. I'm going to jump ahead here.
I believe this scan is actually a little bit later on after some of the surgery had been done.
Sorry, you're correct. That's the recurrent lesion. Sorry. So yes, the CT scan did not reveal any disease, and the abdomen pelvis just showed 2 cysts in the liver, and a flexible sigmoidoscopy revealed a palpable rectal mass 2 centimeters from the anal verge with invasion of the wall, stages T3N0 M0. So the patient had concurrent chemoradiation to a dose of 50 gray with capecitabine, then an APR with a permanent ileostomy, a total abdominal hysterectomy, and bilateral oophorectomy. They completed adjuvant capecitabine through April 2020. In consultation for a periampullary adenoma in October 2020, they decided not to have a Whipple due to the very high risk. And then a patient in June 2021 had a new ovoid mass in the peritoneum on CT scan. And yes, that's the one we're looking at here.
Yeah, so here along the anterior right pelvic sidewall, kind of abutting and deforming the right anterolateral aspect of the urinary bladder, we have this this ovoid soft tissue mass that, in a patient with this sort of history, would kind of represent recurrent disease until proven otherwise. Certainly this would be something that we would want to biopsy, and I think probably this would be something that we'd be able to get percutaneously with the CT guided biopsy, kind of from an anterior approach there. The other interesting thing with this case is it looks like there's some hydronephrosis of the right kidney. I'm not really sure what the etiology of that is. This mass, obviously, recurrent disease in the pelvis can involve, the ureter or the UVJ. In this case, it looks like it's a bit more anterior, not really kind of in the region of the trigone. So perhaps that's an unrelated finding, but just another finding that I noted here looking at these images.
So let's take a step back, because I think it's interesting to talk about this patient's history of FAP. We don't see it all that often, but it's good to talk about. So the patient had surgery for the FAP in 1990 with a subtotal colectomy, assuming that the patient had multiple polyps present at the time. Dr. Weiser, what's your approach to patients who have known FAP, multiple polyps? Do you leave a rectal pouch? Sorry, what's your approach?
So yeah, a lot of it depends on the phenotype. So how they do they present with rectal sparing or not? And the genotype does inform on this as well. And if they are rectal sparing, then it is reasonable to leave the rectum, but it is required that they have close surveillance, which of course is hard to do, especially here, say 20 years later. It's almost always hard to go for that yearly colonoscopy or flexible sigmoidoscopy here. So in a patient with rectal sparing, I think it's reasonable with the caveat that they get close follow-up.
And then from a treatment of their original cancer in April 2019, do you feel like this was an appropriate approach to do directly to go with the chemoradiation followed by surgery? And of course, the surgery being such a low-lying tumor, 2 centimeters from the anal verge, do you think there was no choice but an APR?
Yeah, I think in the setting of a very low tumor, radiation, doing an iliopouch anal anastomosis would have very limited function, and I would urge them to do an APR. I think that's a better option.
Okay. When you leave a rectal pouch, just as for my curiosity, when you leave a rectal pouch, is there any? Could you even do a low anterior resection after the initial rectal pouch surgery?
You could convert that to an iliopouch anal anastomosis where you bring the small bowel down to the anus.
Gotcha.
Function is compromised with surgery, and it's even more compromised with the addition of radiation, but it is possible, but I wouldn't recommend it except in a very, very select case where the patient is urging and understands the limitations.
All right, Dr. Catenacci, a T3N0 adenocarcinoma, 4 months of adjuvant capecitabine. What are your thoughts on that?
Yeah, I was looking at that. I think we don't know what the actual pathology, the response to the neoadjuvant was, but there was obviously residual disease. And so giving some form of adjuvant therapy there, it's a stage 2 cancer, giving adjuvant to complete the full 6 months. And they elected to do capecitabine rather than, say, a doublet like Capox or FOLFOX. I think that this is reasonable, though. This is where also, the MRD assays are coming into play to assess should we be doing something with it. But again, I would urge the patients to enroll on studies in that situation so we can learn what to do.
Yeah, that makes sense. Dr. Fromm, any chance that this ovoid mass in the peritoneum is a desmoid tumor in the context of an FAP?
Yeah, it certainly could be. It's the issue here is that those desmoid tumors tend to be like relatively slow growing, and there's a bit of a gap here in the imaging, but we're told this is a new lesion, and if it just sort of popped up from nothing, I think that it would be the sort of thing that you would certainly want to sample to kind of prove it. But yeah, really, desmoids oftentimes have a non-specific appearance on CT. Sometimes with MRs, we can get some hints that that's what we're dealing with, because they tend to be really fibrous lesions, and they'll have really dark signal on T2 weighted images as a result. But yeah, certainly you would want to think about that in a patient with this kind of predisposition syndrome. The fact that it's a new lesion over a relatively short amount of time, I think would still want to get a biopsy to know for sure.
And then one last tangential question, then we'll talk about the mass itself. Dr. Weiser, from a screening point of view, this patient has known FAP, has had cancer. What's the screening paradigm for other areas of the body, particularly the upper GI tract?
Yeah, I think it is important, as this patient did have a periampullary adenoma or has one, that they get upper endoscopy and lower endoscopy. And then, the question is, as in this case where this is has a low Spiegelman score, this would be observed, but there are cases in which a Whipple is necessary.
Gotcha. Okay. All right. So I'm going to make the leap of assumption because we don't have the information, but let's say the biopsy did show locally recurrent pelvic adenocarcinoma, recurrent from the recently resected rectal cancer. Dr. Catenacci, what would be the next approach?
So this would be around a year after the surgery now with the recurrence. we would be looking at the time frame of that. So, you know, if it's a confirmed metastatic disease, you could go down the path of first-line palliative therapy and getting all of the molecular that you would need to help dictate what you're going to do. I think I'd like to know what the extent of disease is intraperitoneal there for this patient. They're relatively young, and you know, if it's a solitary lesion, we might consider to either do a course of induction chemotherapy for a while and then potentially try and resect it, or if it's a long time after the surgery and it's a solitary lesion, potentially just go and do surgery plus or minus HIPEC. They defer to the surgeon on that. So these would be all the things I'd be thinking about in this situation.
It's an interesting consideration. Dr. Weiser, would you consider upfront resection? And if not, would you consider a laparoscopic look before chemotherapy gets started?
Yeah, I think it's a good point. Laparoscopy could be a challenge due to all the previous surgery. That may be a limitation. I think upfront surgery is reasonable. It is a bit of a short interval, and if we got some tumor shrinkage, that may help the surgery. So chemotherapy or maybe even re-irradiation. I would ask Dr. Patel what his thoughts are on that.
Yeah, no, I think you know, depending on what the field looked like for the first treatment, we would certainly, I think, entertain re-irradiation. You know, a situation like this, I think, if you look at the recurrent rectal cancer data, certainly the best outcomes are for the patients that get resected. And I tend to favor using re-irradiation when we're going to help the resection. So in this case, if Dr. Weiser thinks that we might get a benefit with the pelvic sidewall or something like this, you know, absolutely we'd consider it. In this case, proton therapy maybe is something that's very beneficial with a lateralized lesion. You could use lateral beams with really minimal exposure to the rest of the pelvis. That being said, you know, with it abutting the bladder, radiation cystitis is certainly probably one of the most common toxicities we see with re-irradiation in the pelvis. So I'd be a little worried about that, and for that reason, maybe wanting to start with systemic first. But certainly, I think a good thought in this area if surgery was going to be on the table. If no surgery, you know, I'd be a little more hesitant. I think, again, if this is the only site of disease, we get a good response with systemic. Certainly, it's attractive to consolidate with radiation. And if we haven't had a lot of exposure here from the prior treatment, then again, using the proton beam, I'd push for, you know, sort of a more definitive dose. So 50 gray or above with Xeloda if we weren't going to try to resect it and there was no other disease.
And then I guess last, Dr. Catenacci, your chemotherapy backbone of choice, you know, the genetic testing may modify your antibodies that you had, but what would be your chemotherapy backbone?
Yeah, so you know the only thing that would change from me away from chemotherapy was if it was an MSI high tumor, which it wouldn't be because this is FAP. So yeah, I think that if we're going for it and we want, you know, to get a response, and hence if we're going to go for resection or whatever, you could even consider triplet chemotherapy with FOLFORINOX or FOLFOXIRI. Have to be a little wary of the prior RT. They'd be at risk for cytopenia, as I probably use prophylactic growth factor there. And then, you know, if it was RAF-wild type, probably consider adding anti-TGFR. And if it's if it is RAS-mutant, we would give probably bevacizumab with it.
I have to say that the Italian study with the FOLFOXIRI and cetuximab, you know, that incredibly high response rate, in the very, very limited cases I've had, I've seen the same. It's a really remarkable response.
Yeah, very, very potent.
Good. Any other comments about this case?
The only other thought about going to surgery would be the possible use of intraoperative radiotherapy on the pelvic sidewall if your institution has that available.
Very good. Okay, so let me summarize. There's a lot of factors about this case. So let me actually start with some of the genetics and the FAP, because I think that's an interesting thing to think about and something we is unique to this case. So in this patient with a prior history of FAP, obviously doing the rectal sparing surgery was very appropriate, but the patient really, or these patients do really need to undergo close surveillance, even though it's hard to do that for many, many years, even decades. We talked about the possibility that this could be a desmoid tumor rather than a locally recurrent rectal adenocarcinoma. But of course, the biopsy would tell us that one way or the other for sure. We also did talk about screening for the upper GI tract, and especially in the case of this patient having adenoma, it's something we have to remember for these FAP patients at the risk of other cancers. In discussing the assumption that this is a locally recurrent rectal adenocarcinoma, or really a metastatic deposit, that there is still the possibility of being able to get rid of this cancer. Upfront surgery would not be unreasonable, particularly if it was a slightly longer interval of time. And if upfront surgery were done, even offering intraoperative radiation therapy to the pelvic sidewall could be a possibility. You could consider re-irradiation if the fields allowed it, and proton-based therapy, if it's available at the institution, would be a consideration. But for the most part, offering some additional upfront chemotherapy to try and get some tumor response, maybe with a more aggressive regimen like a triplet FOLFOXIRI, with or without bev or cetuximab, depending upon the genetic results, would definitely be worth a consideration. And then finally, if surgery were too difficult, ultimately, then doing definitive radiation could also be a consideration after a period of induction of chemotherapy. So a complicated case, but a very interesting one.